Hello, my name is Carolyn Randabolio. Thank you for your interest in grief and bereavement support for staff in long-term care homes, a scoping review. My graduate research in partial fulfillment of the requirements for the degree of Master of Arts in the Department of Gerontology in the Faculty of Arts and Social Sciences at Simon Fraser University. I'll introduce the background to the study, then provide a brief overview of the scoping review method. I'll be focusing on the results and discussion, and conclude with reflections on the research process. This project was all about support, so I wanted to start by thanking those who helped me get here, and many more I couldn't fit on just one slide, including my committee. Regarding my positionality, I was an art therapist in long-term care before transitioning to research. The peer support and interdisciplinary collaboration of my MSJ 2ECU family truly inspired this project. For the rest of this presentation, end of life will be abbreviated to EOL and long-term care to LTC on screen. Healthcare staff was selected to represent a wide variety of paid positions in long-term care homes that I'll cover in the methods section. A term that might be new to some folks is a palliative approach to care, which aims to provide good quality of life and relief of suffering for people who have a life-limiting illness and may involve medicine and physical care while integrating psychosocial and spiritual support important to the resident and their support network, including staff. So a little bit of background to the study. Admissions of older adults to long-term care homes are occurring at more advanced ages with more complex care needs, resulting in shorter lengths of stay before death and an increased demand for palliative approaches to care. What's more, frontline long-term care staff can develop family-like bonds with residents through their daily interactions, yet often lack access to sustainable support and have to learn on the job while facing reactions to death in the workplace. When staff bereavement is dismissed or silenced, cumulative grief can lead to burnout, ultimately detracting from quality of resident care. My graduate coursework and professional experience led me to wonder what grief and bereavement support exists for long-term care staff, a question well suited for a scoping review. Scoping review and narrative synthesis were selected as methods to systematically summarize this exploratory research topic. I followed PRISMA guidelines and the six-step framework from Levesque and colleagues, which builds on the foundational work of Arksy and O'Malley and adds consultation with stakeholders to develop summary infographics that I'll present in the results. Narrative synthesis is based on the qualitative metasynthesis framework, also from Arksy and O'Malley, and that's a very roundabout way of saying I use text to describe and answer my research questions. I'll briefly summarize these 6 steps, but they're also detailed in the written report soon to be available on SFU Summit. So step 1, identifying the research questions. Research question 1 asks, what grief and bereavement support is typically available for long-term care staff participating in end-of-life care to foster mental health and well-being? Question 2, what are the best practices and outcome measures for interventions supporting healthcare staff in grief and bereavement that could be implemented in long-term care settings? And question 3, what are the challenges and facilitators in implementing grief and bereavement support services for long-term care staff? Step 2, identifying relevant studies. Using the participants' concepts context approach from Joanna Briggs Institute, this search string was applied to title, abstract, and keyword fields on common social sciences databases in early March 2023 after approval of my proposal in late February. As you can see, healthcare staff was the umbrella term selected to represent over 20 different positions, and this was still not an exhaustive list, with variable regional terminology, while also trying to include unlicensed staff like security and housekeeping. Step 3, study selection. Abstracts were reviewed based on the eligibility criteria on screen. Duplicate articles were removed, and selected full texts were examined with a final list created for data charting. There were no limitations set for country of origin to address gaps in Canadian literature. I'd like to draw your attention to the second to last point of the exclusion criteria regarding COVID. While the pandemic drew much needed attention to the unmet grief and bereavement needs of long-term care staff and sparked my personal interest in the topic, this isn't a new issue and has been part of healthcare discourse for over 40 years. Step 4, charting the data. Using a customizable data extraction form on Covidence, a collaborative online systematic review platform, I independently charted authorship, year and journal of publication, participant characteristics, location, methods, and key findings relating to the 3 research questions. Step 5, results were presented through narrative synthesis, charts, and visualizations. And step 6, consultation. The design of this scoping review didn't involve stakeholders. However, consultation with long-term care professionals and my interdisciplinary peer reviewers was central to the development of summary infographics. There are print versions as well as digital versions available on my website. I was able to lean on my former colleagues and collaborators, including a music therapist, occupational therapist, and resident family physician, who completed an infographic rubric from the National Science Foundation for me. On to the results. A total of 58 articles were reviewed. The majority used a qualitative design and tended to have more exploratory and descriptive objectives as opposed to clearly stated research questions found in the mixed methods and quantitative studies. Most of the publications were authored in North America, led by Canada with 22, followed by the United States with 13. Most European literature was from Sweden and Norway, and differing models of care and cultural factors may have contributed to finding few studies from African, South American, and Asian countries. From West Coast to East Coast, research from 7 Canadian provinces was sourced, 6 from BC, 2 from Alberta, 1 from Saskatchewan, 3 from Manitoba, 7 from Ontario, 2 from Quebec, and 1 from Nova Scotia. It was really exciting to see the bulk of the literature coming from Canada. So the breakdown of participants per staffing category, years of experience in long-term care, age, race or ethnicity, gender, and past palliative education were also charted. Unfortunately, not all studies collected these details and measurements were formatted inconsistently. Conversions would be essential for a future meta-analysis. The aggregate lost racial and ethnic diversity of participants seen in more recent literature, but does reflect some previous palliative education, which ranged in intensity and duration from college courses, modules as part of onboarding, professional in-services, seminars hosted by municipal or regional health authorities, or learning about end-of-life care on the job. So strategies, interventions, and rituals supporting long-term care staff with grief were organized into 5 domains moderated by the effects of time, mirroring the nested systems of the bioecological model from Bronfenbrenner and Morris from 2006. Inspired by Doka's concept of disenfranchised grief and the concept of the grieving circle described by Kasalainen and colleagues in 2017, an article which I really enjoyed reading during full text screening, I imagine the cell-like visualization, including grand-scale social systems that tend to be excluded in other circular models of grief and support seeking after loss. The closest model I could find was for parents after the loss of a child from Stevenson and colleagues in 2016. So this might be a unique contribution for long-term care staff in the specific long-term care context. Starting with time and experience with end-of-life care as a moderator influencing all domains, this means the longer a staff member has worked in long-term care, the more resident deaths they'll be exposed to and can become familiar with the organizational policies and practices specific to the home they work in. It also encompasses major historical events, like COVID probably comes to mind for many of us still. The first domain is cultural attitudes towards death and support seeking. These are ingrained in our individual and collective consciousness and influence our thoughts and actions, whether we know it or not. Next, organizational policy and practice. Most challenges to sustainable grief and bereavement support are present in this domain. Sufficient resources are essential for sustainable initiatives, launching and maintaining supportive policies and practices, and of course, adequate staffing. Palliative skills training upon orientation, in-services, supervision, and formal education were identified as facilitators for increased staff capacity to contribute to resident end-of-life care. Similar to organizational support, workplace-based support focuses on smaller scale initiatives within a specific long-term care home and may include clinical supervision, peer mentoring, in-services, workshops, and debriefings that are scheduled and facilitated by direct supervisors and leaders within the home. Participants responded positively to experiential learning, like shadowing palliative link nurses during visits to their home, and felt this approach was both personal and efficient. Psychosocial and spiritual wellness is fostered through rituals occurring in the workplace, like memorials that are facilitated by staff, as well as participating in research, which can invite discussions about end-of-life care and existential issues in the workplace. Scaling down further in common areas, hallways, resident rooms, and break areas, informal peer support and relationships occur. Family-like bonds and reciprocal support between long-term care staff, coworkers, interdisciplinary collaborators, residents, visitors, and volunteers contribute to workplace satisfaction. And participants from all disciplines highly valued their ability to form meaningful relationships, which translated into a commitment to caring for residents from admission to end of life. Also, relationships beyond the workplace were identified as crucial support for staff. At the center of this model are individual beliefs and self-care practices. Self-care was documented as an important part of individualized coping skills, but many participants didn't know where to begin and felt too overwhelmed to add more off-duty tasks for themselves when balancing multiple caregiving roles on and off the clock. Nevertheless, staff developed private and ceremonial ways to say goodbye, also known as rituals, which I'm excited to discuss on the next slide. As well as personal beliefs to make sense of resident death. Some of these beliefs included acceptance of death as a natural part of life, feeling that death is relief from suffering, and vicarious gratitude for a resident's long and happy life, which isn't a given in many other healthcare settings like Emerge or pediatric oncology. And rituals. Rituals are practices that provide time, space, and opportunities for healing and contribute to holistic well-being when faced with transitions and losses. In the context of long-term care, rituals serve as repeatable, simple acts that provide comfort to gain closure after the death of a resident and reinforce that staff relationships with residents matter, are supported by the organization, and an integral part of quality care. It's important to note that this visualization on screen is based on the rituals that were included in the studies as part of the scoping review and don't intend to imply strict timing. For example, depending on the capacity of any given long-term care home, months might go by without being able to host a memorial, but it may still be beneficial for the community whenever they can come together. I wish I could talk about every ritual in detail, but I'll demonstrate 3 nonverbal rituals that communicate resident death is imminent and subtly inform staff and co-residents that it's time to say goodbye. The first is displaying a meaningful image, either as a plaque or even just a printed photo near the resident's room or on their door. So some common images are sunflowers, butterflies, or other symbol relevant to the home's culture. The second is something as simple as placing a flameless tea light candle on the resident's place at the table. And the third is an altar that can be displayed. I've got it behind me, hard to see. The third is an altar that can be displayed in a common area near the resident's room and also notifies others of the loss over the following days. Rituals like these convey resident end-of-life information in a ceremonial way, but also leave space for individuals to engage at their own level of comfort. So bringing the findings back to the research questions. Research question 1 was more descriptive and well suited to the results as just presented. To summarize, multiscalar approaches from global literature acknowledge that the needs of each home vary, but common calls to action were increasing staffing for more individualized and attentive end-of-life care, ongoing palliative education, and bereavement support, including rituals. Although research question 2 was less neatly answered, the findings offer several avenues for future research. With a lack of evidence-based best practices and consistent outcome measures, I opted to reframe best practices as promising practices, which were characterized by low-cost, low barrier to entry interventions that were culturally competent and could be scaled up and rolled out to other long-term care homes. For example, partnership and ongoing collaboration with hospice staff, palliative champions, and palliative link nurses were globally recognized to boost capacity for end-of-life care and long-term care when long-term care staff perceived palliative specialists as supplementing and enhancing individualized care, as sometimes tensions arose without ongoing interdisciplinary relationship building. So sometimes leading to a bit of an us versus them mentality. That transitions us nicely to research question 3. Most challenges to sustainable grief and bereavement support can be found in the domain of organizational policy and practice. Administrators, managers, and supervisors can suppress staff grief expression and perpetuate a culture of silence surrounding death and long-term care. Insufficient resources were identified as a universal challenge and included underfunding, unsustainable initiatives, and changing or revoking previously supportive policies, practices, and programs due to changes in funding priorities and leadership turnover. Policy was identified as both a challenge and facilitator, especially the lack of policy maintaining unknowns and inactions of decision makers. Hill and colleagues conducted a systematic search of national and provincial level palliative care guidance documents and found few providing consistent high-level guidance for long-term care in Canada. So bringing the findings to the broader discourse, underfunding of long-term care is a women's health crisis. In Canada, most long-term care staff identify as women, yet only 33% of senior healthcare leadership are women. Undervaluing essential services for older adults, especially those living in long-term care, many of whom also live with dementia, highlights ageist and ableist stigma that long-term care staff face by proxy. While not an all-encompassing solution, drawing from the literature in this scoping review, I think finding pride and community in end-of-life caregiving is one avenue to foster workplace satisfaction and challenge negative stereotypes about working in long-term care. And limitations. As with all scoping reviews, this method has several limitations which should be discussed in the spirit of transparency. There was little overlap between outcome measures, so a meta-analysis couldn't be conducted. The design could be improved with additional reviewers and registering a protocol. And the variability of searching global literature means that potentially relevant publications in other languages are excluded, and I might have missed out on other models of care and cultural nuances that influence policy and practice. Also, conducting and publishing long-term care research might not be a priority at this time for specific countries, so there might be innovative interventions out there, but they're not quite in the publication sphere yet. Several limitations arose from the existing studies included in this review, including convenience and purpose of sampling, attracting early adopters and contributing to potential bias, as well as a lack of generalizability, with small sample sizes in the qualitative research and lack of control groups and cross-sectional designs in the quantitative and mixed method studies. Also, the designs tended to suffer from being conducted in only one long-term care site or really specific geographical region. So while the focus of scoping reviews isn't to make recommendations for policy and practice, some gaps that could be identified and addressed in future research include the role of technology in grief support, identifying gold standard long-term care grief measurement for systematic research, and evaluating rituals as interventions. Well, beyond the scope of this project, future reviews, including gray literature, could bring insights from policy briefings, organizational resources, conference proceedings, and dissertations to capture current developments in policy and innovative interventions. Many research participants mentioned these studies were the first time they were invited to speak about their end-of-life beliefs and bereavement experiences. Ongoing discussions of grief and co-creating supportive work environments through research may be a crucial first step toward personal, organizational, and cultural change to address death-related stigma. In conclusion, this scoping review contributes to the recent discourse, amplifying the experiences and knowledge of long-term care staff in diverse roles, all contributing to resident end-of-life care who are not palliative care specialists, and strengthens the importance of expanding the definition of interdisciplinary teams to include paraprofessional and unlicensed staff. The findings suggest that a palliative approach to care which embeds palliative care for residents from time of admission to death through education, collaboration, and affirming interpersonal and community connections through rituals, are all complementary strategies to foster long-term care staff mental health and wellness. And I wanted to close this presentation with some reflections on the research process. It was validating to see similar experiences in the global literature, but it was also emotionally difficult, and I found myself moved to tears pretty frequently. I think the scoping review method provided some distance that I didn't know I needed. And I applied what I was reading and turned to self-care, which for me includes art making. Like this collage I made using photographs of former residents' artwork, as well as journaling. So I kept a weekly journal throughout the process, as well as being able to keep all of my reviewer feedback in here, as well as questions from my defense. And then a little bit of reflection on what are the next steps for me. So it also affirmed how nonlinear grief can be, and I tried to practice self-compassion when timelines didn't go as I anticipated. And I found it healing to revisit pivotal memories of companioning residents at end of life for a new sense of closure as I start the next chapter of my career, including writing letters to residents who meant a lot to me in that journal. In hindsight, I think it would have been totally appropriate to have conducted a traditional literature review, given that I was the only reviewer, but following the scoping review steps and Prisma checklist has enriched my professional research skills as I re-enter the field in a new capacity. And with that, thank you so much. If you have any questions, feel free to reach out to my SFU email or via my website, and please feel free to share the infographics.